Dr. R. Arun is a professor in the Department of Psychiatry in Christian Medical College, Vellore. His interest in health of neglected population influenced him to initiate undergraduate research on occupational hazard among petrol pump workers. The understanding that population health is core component of wellness aspired him to take up public health training in Sri Chitra Tirunal Institute of Medical Sciences and Technology, an institute of national importance. Through his MPH thesis on mental health of old age in home inmates, he continued his passion for health of the marginalized. With strong foundation of public health, he embarked on fulfilling his life goal of becoming a mental health expert. For this, he got trained in psychiatry in CMC Vellore. Following this, he developed an interest in for researching caregiver burden of persons with mental illness. He works with various NGOs including Udavu Mullangal, Mary Home, and Missionaries of Charity. Given the experience, he is the best to give a talk on topic healthcare needs among homeless people.
Thanks, Dheeraj. Yeah, basically, I feel I'm the most privileged person for this conference because I've been identified as a person to talk for the group of people who are voiceless, for whom there aren't much of policies in place. And that category is what we call it as homeless people. To give a perspective, see, for example, 3 years back, we had a lockdown happening all of a sudden in 48 hours. And everybody were told to be remaining inside their home. But then what was happening to these people who are homeless? Where will they stay? Nobody looked at. Then after around 3 to 4 weeks, once the core lockdown was released, everybody was asked to wear masks when they come out. But nobody thought about what about providing masks to these people. Subsequently, there was a long drive for taking vaccination for everyone. But who will vaccinate the people who are having homeless, who doesn't have an Aadhaar card, who doesn't have a ration card, like that? So the difficulties of people who are having homelessness is often going unnoticed. And that's the background in which we are talking about health equity or inequity. So I have organized my presentation in such a way that I will give you a framework on the background of homelessness overall, following which I will also touch upon a few stories in which myself and my team was involved in. So the homelessness, for example, as everyone knows, an individual who is having no permanent living, which means no fixed place of residence. So we often see, I think almost all of us would have seen a homeless person in our lifetime who will be on the roads, who will be either nude or half nude, hasn't had taken care of self very well. But you also have to keep in mind that there is a category called at-risk homeless category, which you have actually touched upon in the morning, a few sessions wherein, see, they're almost on the fringe of becoming homeless. So anything can tilt their balance from having something of that shelter to not having a shelter, not even shelter, their basic needs. Okay, so the typical example will be that which is depicted in that photo. Do you think that as considered as a shelter or not? Okay, so if you include that category also into that homelessness category, we would see that a huge proportion of our population, especially in Southeast countries, will be going into this category. Now, what are the types of homelessness which we always know that no, there are chronic homelessness. Okay, there are episodic. For example, during every monsoon, you will see, or during every natural calamity, you will see, and there will be some temporary homelessness. The other way to look at it is like we always talk about. We talk less about homelessness, but wherever we talk about homelessness is about the visible population who are homeless. There's a huge people who are invisible, which I told you in the previous slide. No, so these are on the verge of being homeless. Plus, there's a subsection of these homeless people who are always serially getting eliminated from the population, which we never know. So they are always dead. One example would be like wherever you get a statistics of people who are homeless, you always see that there is a disproportionate number of homeless people who are men, and women are not there. What's happening to these women, nobody knows. So is it like, how can we explain that kind of a variation? There are, if you take 100 homeless people, the majority will be actually men. Even if you go, now you open your eyes and look around, the majority of people whom you are seeing as homeless in and around will be men. Okay, so there is a subpopulation in this homelessness who's constantly getting eliminated is what our anecdotal observation tells us. And because there's a population, they should also be having some population characteristics, where again, the age can vary from the usual norm. Sex, as I told you, there seems to be a overrepresentation of men in this. And one positive fact of this thing is like they are not fighting based on their religion, caste, and nativity. Okay, whereas people who are having homes might be having strong feelings about their nativity, their origin, their religion, whereas this population most often might not be so much worried about it because even their basic needs are not met. So, and you will see the whole spectrum of people in this category, ranging from children, youth, families. Okay, there are families of homelessness which you will see in urban areas, and elderly. Now, the question is like, how does the elderly come into this group? Can be, see, people who are demented might just walk off from their home. The other possibility is like, see, the family find it very difficult to take care of elderly in the society, so that they will slowly be thrown out of the house. And there will also be youth who are intellectually disabled and all, which the family find it very difficult to maintain them in their home. So take them by train or bus to some other location, leave them there, and come back. We might find it very cruel or not happening, but in our practice, we have seen these things happening. And it also need to be highlighted that because it's a byproduct of urbanization, at least a few, the settlements of this population can often be found in areas where there is high economic activity, where there are connections through rail or roads. Okay, so you will feel a, a aggregation of homeless people in and around economic zones or in travel areas. Now, coming to the topic of health of homelessness that we are talking about, but yesterday plenary section it was highlighted that, see, the health is also, or equity is also about wellness. But when you're talking about people who are having homeless, we have to understand that, okay, what about their wellness to begin with? Now, they are the people who are below poverty line. They are the people who are subjected to social exclusion. They are the people who are always experiencing relative disadvantage. They often see the greener side next to them. So they always are subjected to relative disadvantages in a society. They're often subjected to abuse and trauma. So to begin with itself, they don't have much to talk about wellness. And the second part is obviously illness. So when we talk about health of homelessness or healthcare of homelessness, we often have to consider that their wellness is already been affected. Top on that, they also have their illness. Now, coming to the descriptives of the illnesses, you will see that there can be health problems causing homelessness. As I told you, a person who is having intellectual disability can be thrown out of the house. A person who is no more contributing to the family, typically a elderly person, can be taken out of the house. So all these are some of the conditions. And there can also be health problems due to homelessness, which we will come to. So there is a constellation of a whole lot of medical conditions, obviously infective conditions, like because of their poor nutrition, poor living conditions, they are subjected to infective condition, including chronic conditions like tuberculosis. Obviously non-communicable diseases also. There are a lot of injuries that are reported in this population. Their hygiene will always be under compromised situation, because so there are a lot of dental and dermatological conditions. Nutritional deficiencies for sure. Obviously, obstetric situations are also noticed in this population. Now, malignancies can also be seen, but it's very difficult to detect in this population because nobody pay attention to it. Okay. Now, the other spectrum is what we call it as psychiatric conditions. Because what can happen when there is a severe mental disorder, which included most of the psychotic disorders, like these people can sometimes run out of their house, out of their suspiciousness, out of their manic state, and they reach a point where they are not in a position to think for themselves. So their thought process is affected, their ability to say who they are, their ability to say from where they are coming from, who all are there, means who all are there in their family. All these things can sometimes be affected over a long period of untreated severe mental illness. So when you take a population of homelessness, you often find that a reasonable number of them are having psychiatric comorbidity, and which will be severe mental illness. Now, there's another set of people who are having common mental disorders because they are always having in the negative side of wellness. So they often goes through mild depression, anxieties, and all. And it is well reported that addiction is one of the way out in this category. No. So addiction is quite common, and obviously dementia can also be overrepresented in this population. The reason why we should know about all these things is like when we are thinking about an equity or addressing inequity, these are some of the areas which you need to prioritize when you are thinking of healthcare needs. Now, all these diseases what we talk about all happens in a milieu of unmet needs. And these unmet needs include their nutrition not being addressed, their wellness not being taken care of, their human rights not being valued. They often get into an encounter with the legal system. There is nobody to have an advocacy for them. And often this is reported as a byproduct of the so-called development or urbanization. So then if you want to reverse this, then you have to go back from urbanization, one way of looking at it. So there will definitely be a lot of barriers to it. And to add to all these things, what we have to understand is like they are not accounted for, or they are not accounted as citizen or are as existing anywhere. Because as I brought out in the initial slide, see, they are not represented either in the voter's ID or having an Aadhaar card or having a ration card. They are not in the enumeration list at all. Okay, so in this milieu only, this healthcare need of these people need to be looked into. So what are the challenges that we can anticipate? The challenges can be in the health system. The challenges can be within the health professionals. The challenges can be from the homeless themselves. So in the health system, for example, most of the health system is structured in such a way that we provide a institution-based care. But here we are talking about people who are not having home. Okay, so there is a contradiction there. And definitely, I think today in our one of the meetings also, we are saying that whatever said and done, out of pocket expenditure is huge in our country. And here we are talking about people who are below poverty. Then there is always a question of stigmatizing people who are homeless. And traditional healthcare system often is dissociated from the social department or other initiative. So if you are truly thinking about providing healthcare to people who are homeless, we definitely have to have a association with other departments. Okay. And many of the healthcare delivery is through a serial system. For example, immunization has to happen in series. Obstetric care has to happen in series. Okay, NCD management, you need to follow up the person, but we are talking about a subset of population is always on the move or floating. Okay, so our healthcare delivery system is also not apt to the characteristics of this population. As health professionals, are we sensitized during our training? Means I doubt that. And here, if you have to provide or if you have to bridge the inequity in this population, the solutions can't be medicines alone. But unfortunately, what we are focusing more on medical care. The standard treatment algorithm may fail, which was very well pointed out in today's morning session. Like we have to move beyond the evidence-based practice to practice-based evidences, and we have to modify the guidelines also. The profile of medical and surgical conditions might also vary. So you see, the challenges can come from the health system, the challenges can come from the health professionals. It's also true that there can be some resistance from the homeless individuals themselves, because their priorities can be different. When their basic needs are not being met, will they consider health as a priority? It also need to be looked into. So an appropriate healthcare approach, if you have to bridge the inequity in this population, would be, obviously, if you look at treatment, what can be the treatment for this category? Housing, because that is what they are lacking. Okay, so there is a basic need which is lacking, which needs to be brought back to them. Having said that, yes, we need to move from a tertiary care approach, secondary care approach, primary care approach to a public health approach. And if you are individually looking at, okay, you want to give an individual one set of treatment, obviously you follow the thumb rule. You bet on your clinical judgment. Okay, you limit investigation to the need. You simplify the regime. So most of our morning sessions were actually talking about it. So luckily, the sessions which are happening in Hall B was talking more about this. Like, no, you don't go by the standard guidelines. You need to have a regional guideline or a guideline which applies to the context. Okay, you don't go by the go by very complex regimen of drug delivery. Make it simplified for the client. You don't go beyond the behind the investigation. Rather, you focus much on your clinical judgment. But this is all about giving an individualized care. But on a bigger picture, what we need to do is, like, I would emphasize on the point of networking, because this is a group where health is closely connected to social determinants of health. So we need to network with a different set of people, which include the public, which include NGOs, which include socially committed elements in the society. Okay, so all these things have to put their effort together to bring in or to deliver healthcare to this group of individuals, so that the health inequity in this group can be addressed. So moving on to a few stories that we have encountered. So on the left side is an individual who is, from the picture, it is evident that he has sustained a burn. It is halfway through healing the burns, but basically he is a middle-aged gentleman who is almost like at risk of losing the house. He's also having severe mental illness, and secondary to that mental illness and the difficult and the thought process he's having, he actually climbed onto a transformer and he sustained burns and he fell from height. Now, see, this individual's health needs would include taking care of the fall from height, taking care of the burns, taking care of the severe mental illness. But ultimately, this person will need a few months in a facility to recover. Who will be the bystander? For example, in our health facility, we always need a bystander, because we are a system wherein we always rely on the family as a support system. But here we are talking about a system, a group of individuals who might not be having that kind of a social network. Okay, so these are some of the challenges that we can face when we are thinking of providing care to a homeless individual. But so through lot of networking, we were actually bring him back to a healthy state, as is shown on the right side, which actually included CMC actually provide us a lot of support for this, because here we have many departments. Here there are socially committed elements. Moreover, there is an NGO which is working on this area, which I will highlight on. Okay, so like this individual, I would say, was lucky enough that he could come out of this, but not everyone has that advantage or the luck. Now, this is another story wherein the lady who's standing in the middle, Again, this happened during the COVID period. From that picture, you will know that most of them are wearing masks. This happened in the COVID period when, see, she just walked into the um, department or to Vellore, and we found that definitely she is also not in a stable state of mind. Along with that, we are not able to identify the family members. Along with that, it is a pandemic. Along with that, it's a female. So she is at risk. Okay. So what we could do is like through networking, we could actually arrange a facility for this young lady so that she can be placed, a shelter can be provided, a safe environment can be provided, and a care can be provided, and finally she could be reunited. Okay. Now the two people who are standing there from the um, um, dress itself, you can make out that the one person is actually a driver. So he's not at all related to CMC, he's not all related to our department, not related to the individual. But see, there is a lot of potential in the community which we can tap, which can actually help these people who are in need. And one more addendum to the story is like, after all, we need to transfer a female patient to a long distance through a male person. So now we wanted another female also there. So that's that lady who's in burqa. So she also volunteered to, okay, I will also accompany you. So you see, you need to network and capture on the capital that we are having rather than waiting for the ideal opportunity. Now, this is another story. Both stories have a positive ending. Okay, so the person on the picture on the left side depict that during his middle age, he actually wandered away from his home. So how we came to know it is like we got an information that there is a wandering mentally ill or wandering person, a homeless person in Vellore. Okay, the usual picture, like he's not well kept. Okay, wearing multiple clothes, not taking care of self. Now the person got um, um, recruited to one of the NGO called Udav Mullangal, which is actually working on homeless mentally ill people. So they're actually doing a very brilliant work wherein they provide shelter, they provide nutrition, they take care of the individual self-care, and if something more is given in terms of medical and psychiatric care, in a period of 1 month or 2 months, they will become independent in maintaining themselves. And during that initial 2 months, if you ask them, they might not be able to say who they are, from where are they coming from. Okay, none of this information will be there. But over a period of 2 to 3 months, they will be in a position to say that, okay, I am Mr. X, I am from this location. It may be correct. Then you need to keep tracing those information. And if it is an accurate information, okay, we can find out their family as early as possible. Many times it might not be an accurate information, but you keep trying. So over a period of 6 months to 1 year, the Udumulangal have been able to trace majority of the family of origin and were able to contact them. And an attempt is always made to reunite with the family. So though I told all these things in 1 minute as a short story, there's a whole lot of input and effort going into this from multiple people who are involved. Okay, so but this is the pathway through which this particular NGO is working. Okay, and now this individual again was lucky enough that the family was contacted and the wife was told to arrive at Vellore or Tirupatur, and and wife took him back to his native. Okay, so if you talk to that NGO, you will see n number of stories like this. But on the other side, you will also hear n number of stories where the family said, "No, we are not taking them back." That's also there. Okay. On the right side, again, it's another story wherein an individual from Northeast landed up, and again, through the same process, the family could be identified and taken back. So these are all stories from Vellore. So you see, people from Northeast are reaching Vellore, people from Delhi is reaching Vellore. Same way, people from Tamil Nadu might be reaching other localities as well. So to conclude, the lessons that we have learned is like, if you want to have to address inequity in the population of homelessness, first you address their diet and housing because their basic need them itself is at stake. We can always look for various models like static model or a mobile unit. The static model basically means you need to have a place where you deliver all these things. Mobile is like you go and trace them and identify them and deliver care there itself. Okay. And obviously, you need to have a basic assessment of their basic medical health and physical condition. Along with that, you also need to take care of their mental health also, because a reasonable proportion of these individuals can have mental health needs also. And in that LCSU model, it was proposed that it's always good that the same personnel attend to the same individual, because that will actually bring in a lot of connectedness in the healthcare delivery, which is also true in this scenario as well. And you cannot always think that, okay, there is one particular algorithm, one particular protocol will work. You have to think about different sources and targets and fine tune it towards the need of this individual. So that's about from my side. I just conclude by acknowledging the entire team, because all current and retired clinical and non-clinical staffs in Department of Psychiatry. I definitely have to mention Dr. Anna Therian, who has initiated this process. Various staffs from other departments, CMC has helped us. There's an NGO, Udo Mullangal, which has started from Vellore, now branched out to Tirupatur. And Udo Mullangal, the person who has started Udo Mullangal in Vellore, Chandrasekhar sir is here. So thank you, sir. And definitely we need to thank the Department of Social Welfare, because we need to network. Network means there has to be government facility as well include. Obviously, there's a lot of resource in the public. So though I told many negative things about this, how does these homeless people survive in the community? Because the public is supporting them. So there's quite a lot of resource in the public which we need to tap. Thank you.
Thank you, Dr. Arun. There are a couple of questions. One is regarding what are the challenges from legal point of view? There's another person asking in similar lines. What does the Mental Health Act say about homeless people?
Yeah. So the legal challenge would be if you're truly speaking in terms of mental health alone. Okay, so there's a Mental Health Act 2017, which actually says that the government machinery has a responsibility to take care of individuals who are homeless, and they need to be evaluated in a public establishment, and a provision for their rehabilitation need to be provided. Now, having said that, this pathway has a lot of barriers. That is where Udo Mullangal and similar NGO had to pitch in. So on one side, we definitely have to make sure that the MHCA, what we call Mental Health Act 2017, is strictly being followed. At the same time, we also have to understand that there is space for NGOs to help the homeless.
There's another question. There's some questions about government setups. One question is, where should this network be pivoted and who takes ownership of it? And if such a model can be scaled up in government, is it practically feasible and are the budgets possible? Another person has noted that homeless patients are neglected in government hospitals. So what can be done for improving healthcare in government hospital setups?
Now, see, there is actually a initiative from the central government to bring in provisions to care for people who are destitutes. But as of now, I think it has been shelved. So we need to work on it. 2016, I think a model bill was in place, but nothing has moved beyond that, is what I understand. But we should also understand that different states have their own models in place. For example, in Tamil Nadu, you will see night shelters. There are certain provisions for women. Okay. So, and the Udo Mullangal, for example, though it is an NGO driven initiative, the administrative head for that is a collector. So you see there is a public-private partnership happening there and collaboration happening there. The thing is like we need to have, we need to find out, okay, who all are interested, what all facilities are available both in private sector and public sector, and try to bring all these things together. Now, where to connect all these things, I would say that it always depends on a socially committed team.
Uh, uh, Another person has asked, how did we tackle the issue of housing, uh, the permanent type of housing after the hospital discharge? And another person has asked, does CMC admit homeless patients without attenders? And where do
So,
they go after discharge?
yeah. So as I told you, see, the treatment for homelessness is providing them home. Okay, but then again, it's a process. Okay, that's where I think the government has actually come up with a few suggestions, but it has not materialized so far. Okay, the second thing is like, see, I gave you that example of a person being treated. There are provisions. I understand that many hospital doesn't accept people who are homeless, but in CMC, I have seen people. If you can entrust that there is a caretaker, there are options available. Though it is not a common occurrence, there are rare instances wherein a homeless person has been taken care of till an alternative facility has been made available for the individual. You might also be able to tell about that. With, no, recently also we had a situation.
Yeah. Recently, we had a patient who said there's an atom bomb in his neck, and he wants us to remove it. So he has no caregiver. So what do we do? He could use a knife and cut open his throat. So we actually took him to our emergency, psychiatric emergency, admitted him there, provided food, uh, arranged some caregivers, so the staffs were providing everything. And finally, the family members came, and currently he's being treated. So, so we do have a protocol in CMC to help people if there is no caregiver. We have to inform the medical superintendent office. We have to inform cops if required. And there's a protocol. Anyway, if you want to know, you can get to know it. Thank you so much, Dr. Arun. Uh, yes, sir.
We have they have provided us volunteers who have been the bystanders for severe mentally ill people who had acute medical needs.
Yes, and actually in the house we have the founder of Uduvu Mullangal, Mr. Chandrasekhar, who's actually come. He's been in attendance the whole. Sir, Urudar நினைக்கிறீங்களா? He's Mr. Chandrasekhar who founded Uduvu Mullangal. Uh, mm. So, sir is actually telling how we could help a person who's stranded, who is homeless. Our job is to go and meet the local police station, report, file an FIR, and it's the cops will take the person to a psychiatrist and get that there is a any doctor and get that there's some possibility of mental illness, and then they have to take to the magistrate, get a reception order, and then with that they can be taken to any government hospital setting and they can be admitted. So this is the protocol that is followed. Right now the status they're still following that, right?
No, that's right. There are a lot of barriers to that
Yeah.
pathway, but we need to keep
Yeah, I
knocking the
remember
doors.
many years ago, Mr. Chandrasekhar had taken some people like this, and after some time when he turned back, the same guys were all outside the police. Again, they were let free. Ah, okay, okay, thank you. And then he immediately left out
Yeah.
into the community without any care. Uh, so, so, yes, sir. To-
avoid that only that means. To
So
avoid
basically,
that,
anyone can illegally detain anybody, right? So the magistrates are getting involved to prevent illegal detention. So that's Professor Madhiharan from Tamil Nadu Services, retired. Thank you, sir. So our job is just to report to the police. After that, it's done. If there is nothing more, we could uh, wind up the session.